This lecture is going to be on Chapter 9, Leukopoiesis, white blood cell differential, and lymphocyte function. Here are the objectives of what we're going to cover in this lecture. So by the end of this lecture, you should be able to describe leukopoiesis and the primary purpose of white blood cells, list the maturation sequence of the granulocytic series, name 4 morphologic features that are helpful in differentiating the cells of the granulocytic series, define the major CD markers for each individual leukocyte, define the function of the myeloid stem cell relative to the lymphoid stem cell, characterize the difference between absolute and relative values, describe the lymphatic system and its relationship to lymphocyte production, describe the role of T cells, B cells, and natural killer cells. So leukopoiesis is a term that means the production of white blood cells. And so the term for WBC or white blood cell is leukocyte. So therefore you can see the root word in the leukopoiesis. The primary function of our white blood cells is to defend against various things like bacteria, viruses, fungi, and other foreign substances. Our leukocytes contain granules that have enzymes that are used for digestion and destruction. We'll talk more about the granules as we get further into this lecture. Leukocytes are located in your bone marrow. They're in circulation in your peripheral blood, and they're also found in tissues. And some of these white blood cells are stored in the spleen, which we talked about in our Chapter 2 lecture. So we've already discussed that leukocytes mean white blood cells. We also have the term myelocytic and granulocytic, or myelocyte or granulocyte are actually terms that can be used interchangeably. One thing that you want to make sure you take note of is when you see leukocyte, myelocyte, granulocyte, it all is indicative of discussing some aspect of the white blood cells or the white blood cell population. So with the production of white blood cells, they have more of a complex maturation cycle than erythrocytes or red blood cells, because we have 5 mature white blood cells versus only 1 mature red blood cell. They may only spend hours in circulation. A white blood cell may only be in circulation 8 to 10, 8 to 12 hours, whereas a red blood cell's life cycle is 120 days. So all of the white blood cell production originates from the pluripotent stem cells, and then from that stem cell you either have the lineage of the myeloid stem cell, which is going to be for your neutrophils, your monos, your basos, your eos, even your red blood cells and your platelets. And then you have the lymphoid stem cell, which is going to give rise to just your lymphs, and we'll talk more about that shortly. So the lymphocytes originate from the bone marrow and the thymus, which is part of your lymph system. Is in the upper part of your chest. So this gives you a little snapshot of the origin and maturation of the granulocytic series. So you can see that we start with a myeloid stem cell, and when interleukins, which are like hormone type stimulators and growth factors, are applied, then you have rise of you can see in parentheses GEMM, granulocytes, erythrocytes, monocytes, and macrophages. Then you have the CFU stands for colony forming units. Then you have MEG, so you have interleukins and growth factors that stimulate the production of megakaryocytes, which are your precursors to your mature platelets. The CFU EOs, which is the same process of the hormones and growth factors giving rise to the production of eosinophils. And lastly, the CFU BAS, which is the process of which the basophils originate. So when it comes to the leukocyte maturation, your job as a tech is to evaluate various aspects of the cell to determine the actual age of the cell, the maturation of the cell. So one of the first things you look at is the cell size. We also look at the nucleus to cytoplasm ratio, the chromatin pattern, the presence or absence of nucleoli, the cytoplasmic quality, the presence of granules, and we also look at CD markers if those are available. CD markers are surface antigens or molecules that are used to classify the different stages of the cell, and it helps with differentiation of the cell. So here we have a little chart that shows the white blood cell maturation cycle. So we're going to start with the mother cell or the myeloblast. The next stage into maturation is the promyelocyte. Then we have the myelocyte, which is the last stage to divide. Then we have the metamyelocyte, the band, and the segmented neutrophil. So this is the granulocytic line for the neutrophil. So here we have the starter, the mother cell, the myeloblast, and those criteria that I just went over of what we use to evaluate and differentiate the cell. We have the size, which is 14 to 20 micrometers. The nucleus to cytoplasm ratio is 6 to 1. You can see the darker purple area, which is the nucleus, is much larger than the cytoplasm. You can see on the periphery of the right a little span of cytoplasm and a little bit on the upper corner. Well, it's not really a corner, but the upper, 11 o'clock on a time clock, a little bit of cytoplasm there. So you can see what the nucleus to cytoplasm ratio, the shape of the nucleus is round or oval and indented with a central nucleus, and the chromatin pattern, it's got thin chromatin strands. You can also see that the color of the cytoplasm is moderate blue, and it's usually without any type of granules, visible granules. 2 to 5 nucleoli. You can see just in this small image, I can see one nucleoli about 12 o'clock at the top there. I don't know if you can see here is the nucleoli right there. And it does indicate CD markers for 45, 38, 34, 33, 13, and HLA-DR. When it comes to the CD markers, just be aware of those. We have to make sure we cover those in case you see those on your certification exam. When you are sitting down as a bench tech, this is nothing that you would be privy to or be able to determine on your own. It's more of the other aspects that I've gone over with size, the nucleus to cytoplasm ratio, etc. The next stage in the maturation process past the myeloblast or blast is the promyelocyte. And here we have a size of 15 to 22 micrometers. The nucleus to cytoplasm ratio is 3 to 1, so you can see it's a lot different than the blast, where you can see much more of the cytoplasm on the outside of the nucleus. The nucleus can be oval, round, or eccentric. Eccentric meaning it kind of leans to one side. You can see with this bottom one that it's leaning on this side. Forgive my drawing, but it's more to the left side of the cytoplasm. So if you see eccentric, that's what it indicates. You also have light or red purple chromatin. The cytoplasm is going to be moderate blue color with fine to large blue or red or purple looking azurophilic granules. Azurophilic means it takes on those blue dyes when it's stained. You will be able to see 1 to 3 prominent nucleoli. Unfortunately, this image is so small, I cannot point out the nucleoli in the nucleus for you. I also wanted to mention that you want to take note of what's in the bone marrow and what would be seen in the peripheral blood. So here, the bone marrow, the promyelocyte is going to be 2 to 5% of found in the bone marrow, and then in the peripheral blood, which is what you see when you do a differential from a CBC or complete blood count, you shouldn't see any of these. So when we do see these immature cells, we know that there's something going on with that patient. Just like with the even with the blasts on the previous slide, those are only up to 1% of what's seen in the bone marrow, and it should be 0% seen in the peripheral blood. So just keep that in mind, that when you see those, it indicates that there is an issue with the patient. Next, we have the myelocyte, which is 10 to 18 micrometers. Your nucleus to cytoplasm ratio is 2 to 1. This bottom cell is not a myelocyte, so don't look at that one, the top two. You can see that the nucleus is eccentric on both of these. This is more towards the top, this is more towards the bottom. The chromatin pattern is much more condensed. You will not be able to see nucleoli once it reaches this stage. The cytoplasm can be a dusty blue. You're going to see fine and granules like the red and blue granules. This is going to be only primarily, like I mentioned in the previous slide, 5 to 19% seen in the bone marrow. You should see 0 of these in the peripheral blood, of which you will see as a hematology tech. This is the last stage before it starts, the last stage to divide, and here are your CD markers for the myelocyte. Next, we have the metamyelocyte at 10 to 15 micrometers. The nucleus to cytoplasm ratio is 1 to 1. This is a much closer image, so it's easier for us to take a good look at. The chromatin, the nucleus is going to be kidney bean shaped. You can see, let's see, it starts to indent kind of right in here. So it gives the illusion of the kidney bean shape where it's indented. You will not see nucleoli in the metamyelocyte. The chromatin pattern is much more coarse or clumped. The cytoplasm is going to appear to be more of a pale blue color, sometimes a pinkish like underhue with moderate specific granules. Again, this is seen in the bone marrow, 13 to 22%, and it should not be seen in the peripheral blood. And it's going to have the same CD markers as the myelocyte. The next stage in the maturation is the banded or band neutrophil. The size is going to be 9 to 15 micrometers. The chromatin pattern is going to be C or S shaped, and you can see that here, this darker purple has banded out. And you're going to see no filament. So once you start to see a little filament, it starts to seg up, and you'll see that better in the next slide. You should lean more towards being conservative of what you call a band versus what you call a seg. The cytoplasm is going to be pale blue or pink with fine specific granules. There is, you don't really get into evaluating the nucleus to cytoplasm ratio because the cytoplasm typically predominates what's going on once it reaches this stage. Now the bands can be seen in a normal peripheral smear. It is seen in the bone marrow as an immature cell, 17 to 33%, and you can see that again in the peripheral blood, 0 to 5%. And the last stage for this is the segmented neutrophil. You can see the little figments here separating the little globs of the nucleus. That's why it's called a segmented, because each thing is separated at this point. So the size is 9 to 15 micrometers. For a normal, what's considered a normal segmented neutrophil, you're going to have 2 to 5 lobes of the nucleus connected by filaments without visual chromatin patterns. Cytoplasm is pale lilac, many fine secondary and dust-like granules. It can be seen in the bone marrow 3 to 11%, but in the peripheral blood, you're going to see it 50 to 70% because this is what you anticipate seeing in a normal blood smear. So 50%, 50 to 70% of your white blood cell differential should be the segmented neutrophils. The main function of the segmented neutrophil is to aid in the body's defense. And again, they're seen in a normal PS meaning peripheral blood smear. The next cell that we're going to discuss are the eosinophils. You can see the size is 10 to 16 micrometers. When it comes to the nucleus to cytoplasm ratio, you can see that the cytoplasm predominates the nucleus. The nucleus is going to be round to oval and eccentric, and it's usually bilobed. You can see here, you've got a lobe here and here. Forgive my less than accurate circling, but you can see what I'm talking about here. The nucleoli is not going to be present, or not visible rather. The chromatin pattern is going to be coarsely clumped. The cytoplasm, you're going to have large red to orange or pink looking granules. This is in the bone marrow 0 to 3%, and you will see this 0 to 5% in the peripheral blood smear. Now, the eosinophils are responsible for targeting parasitic infections, allergic reactions, and hypersensitive reactions. Basophils are going to be 10 to 14 micrometers. Again, like the eosinophil, the cytoplasm predominates. It's going to have a very coarse and clumped chromatin pattern in the nucleus. It is typically is going to be a bilobe nucleus with large dark granules. Sometimes it's hard to see because of those larger dark granules, the nucleus as well. Sometimes the granules are more thinned out and you can see the nucleus better. You will not have visible nucleoli. The cytoplasm is going to be very dark, like purple to black granules. In the bone marrow, it's less than 1%, and in the peripheral blood, it's going to be 0 to 1%. The basophils contain histamine and heparin, and they are part of the body's response to hypersensitive reactions. Next, we have the monocyte. So we have the monoblast, and it's going to be the same description as the myeloblast. And it is hard to determine visually. This is just a regular old mature monocyte in this image here. A promonocyte is going to be 12 to 20 micrometers. The nucleus is going to be irregular with an indented chromatin. And you're going to see here you've got this grayish blue cytoplasm. And typically you do not see a promonocyte in the peripheral blood, and in the bone marrow it's less than 1%. This is the same image of the mature monocyte. I just blew it up a little bit bigger on this slide. It's going to be the same size, 12 to 20 micrometers. The nucleus is variable. It's going to be all different types of shapes. It can be round. It can be like a horseshoe shape. And in the chromatin, you might have like brain-like convolutions where you can see, it's harder to see on this image. The chromatin is loosely weaved, lacy, open, and thin. So you can kind of see spaces within the chromatin. The cytoplasm is going to be this grayish blue color. You might have pseudopods, which means it looks like finger type extensions that kind of look like they're reaching out. You also may have numerous vacuoles that you will see within the cytoplasm. The nucleoli is not visible in a mature monocyte, and then the bone marrow, it's going to be about 2%, and the peripheral blood is going to be 3 to 11%. The next cell that we're going to discuss is the lymphocyte. So we have the lymphoblast, which is 10 to 20 micrometers. The next stage would be the prolymphocyte. It's going to be a little bit smaller at 9 to 18 micrometers. Then you have a small lymphocyte. Sometimes they look smaller, sometimes they look larger. I actually added an extra slide just to kind of cover that. So this is an image of a smaller lymphocyte, 7 to 12 micrometers. Typically, the nucleus of a lymphocyte is the same size as a red blood cell, a larger red blood cell. So you can see here the nucleus predominates. You just have a little bit of cytoplasm on this left side. Then if you look at this larger red blood cell here down below, it's about the same size. So that's one way that you can gauge that when you're looking at a slide. It's going to have a lot of clumping in the chromatin. It's very condensed, looking very dark. A larger lymphocyte is going to have more apparent cytoplasm, and we'll get to that on the next slide. So actually this next slide we're going to go over a little more in detail of the smaller looking lymphocyte. So the nucleus is going to be round to oval. It may be, you might have a slight indentation. This one does not. The chromatin pattern again is condensed to deeply condensed, very dark and consolidated. You can see occasional nucleoli. In the nucleus, the cytoplasm is very little to moderate. It's going to have more of a lighter color, a lighter purple or sky blue, and you may actually see vacuoles. Typically, you won't see vacuoles in a smaller one like this, but in the larger lymphocyte where you are able to see the cytoplasm much better, you may have vacuoles. So that's why here it says the nucleus to cytoplasm ratio can be 3 to 1 to 5 to 1, just depending on the size of the lymphocyte, and they both, whether large or small, can still be considered a normal lymphocyte. So in the bone marrow, you will see these 5 to 15%. In the peripheral blood, what you will see is a bench check. They're going to be 20 to 40% of the overall 100 count that you do on a differential. Here is an image of a larger lymphocyte. It's got the same specifications as the smaller one. You can just see that there's a much larger area of cytoplasm. Because you can see the cytoplasm better, you can see that there are granules here, lots of them here. It's just more apparent just due to the increased size. You may actually also see vacuoles. Here's some little small vacuoles here in the cytoplasm. In the bone marrow, it's going to be 5 to 15%, and again, in the peripheral blood, it's going to be 20 to 40%. So for lymphocytes, the primary locations that those can be found are in the bone marrow, the thymus, which is the gland that's a part of the lymphatic system. This is where the thymus trains white blood cells or T cells, which is a specific type of lymphocyte. Secondary locations for lymphocytes are the spleen, the lymph nodes, Peyer's patches of the GI tract. These are like lymphoid follicles that aid in our immune system. They help to identify and destroy pathogens, and they also can be found in the tonsils. When it comes to the body's defense, we have the lymphatic system, which is responsible for our blood filtration, our fluid balance, antibody generation or production, and lymphopoiesis, which is the production of lymphocytes. So the production of lymph or clear fluid that bathes all of our soft tissues. It is not moved around by any type of pumping mechanism, but it circulates from our respiration, our muscle movement, and nearby vessel pressure. We talked about briefly before what CD markers are. They're surface antigens used to classify different stages on the cell. So here we're going to talk about specifically B lymphocytes, which are 10 to 20% of our lymphocytes. They derive from our bone marrow stem cells, and they are activated by IL-1 and IL-6, and those are a particular type of cytokine that are used in our immune response. The mature B lymphocytes can move on to become plasma cells, and those secrete antibodies. It also plays a role in our humoral immunity, which is when we have antibody formations. The body is triggered by an antigen and therefore stimulates an antibody production to that antigen. And the mature B lymphocytes can be found in our bone marrow. The T lymphocytes are 60 to 80% of our lymphocytes. They aid in cell-mediated immunity, for example, with like tumor suppression. You have T helper cells, which are CD4 cells, or T cytotoxic suppressor cells, also known as CD4 cells, and those mature in the thymus, as I mentioned earlier. We also have natural killer cells, which is less than 10% of our overall lymphocytes, and they play a role in resisting bacteria, viruses, and even fungi. Here we have a diagram that kind of breaks down what we just talked about. We have the lymphocyte stem cell. Then when it comes to the thymus, what originates from the thymus is the T cells, which is 60 to 80%. And of those, you have the T helper cells and the T suppressor cells. Then you also have lymphocyte stem cells that operate in the bone marrow, where you get B cells, which is 10 to 20%, and our natural killer cell lymphocytes, which is 20% or less. When it comes to the leukocyte count or the white blood cell count from our CBC or complete blood count that we run in the hematology department of the laboratory, we usually have very large instruments that do the counting for us by automation. There are reference ranges that are created to determine if those counts are normal. Then we also have critical values that are going to be flagged. The instrument's going to flag that for you, and you as a tech are going to be responsible for reviewing that, troubleshooting that if it's not compatible with life, or determining if a peripheral smear should be made and evaluated by a tech. So usually those parameters are set up when the instrument itself is set up, and it will let you know. The instrument's going to say, hey, we don't like how this looks. We think there's some immature cells. We want you to do a slide and determine that. So the peripheral smear is going to be evaluated for the distribution multiplied by 10. The estimated count is multiplied by 40, and you're going to look at that differential count on the oil immersion lens on the microscope. So you're going to count 100 cells and differentiate those and put them in the correct category, and that's going to be reported out in a percentage. You're also going to look at your red blood cell morphology and your platelet morphology and determine if what you are seeing is jiving with what the instrument has given you in its report. So here is a chart that shows you what you would anticipate seeing in an adult and up to a 1-year-old for a normal, what we would call a normal white blood cell differential. So typically, segs are going to be the cell that you see primarily. So 50 to 70% of what you see should be segmented neutrophils, and you might have a few bands in there, 2 to 6%. The next population you anticipate seeing the most of are your lymphocytes at 20 to 40%, and then the rest is going to be the most prominent would be your monos, then your eos, and then your basos. It's nothing to do with differential. You can work in a hematology department daily and do manual differentials, and you might only see one baso the entire week because they are the least of the population. So that's what you're going to anticipate seeing, and anytime those numbers shift and the percentages change from what you're seeing on this chart, then that indicates there's something going on with the patient in various ways. Here's a chart on what the textbook is saying to when to consider counting a manual differential for a first-time patient. Again, those parameters are usually set up by your facility, by your department, by your instrumentation. These are just a few things that you can kind of give you an idea. A white blood cell count that's greater than 35 multiplied by its quantifier, which is 10 to the 9th per liter. Lymphocytes that are greater than 40%, like we talked about, anytime there's a shift in the population, that it's usually an indicator that something's going on, or even less than 17% if the lymphocytes are too low. Monocytes greater than 12%, blasts, especially for a first-time patient, and you have no previous blood work that shows that this has been determined that this is happening with the patient. And again, here at the bottom it says these values vary with every clinical site. Delta checks are something that help us determine what we're doing. It's a quality check, a quality control type of thing. So if a patient has a abnormal value, you want to look at, do I have a CBC from this patient previously, and what were their values at that point? Sometimes they can vary so much, and there is no disease state or any problems that you know, especially if it's a patient on the floor. Then you might have to look at pre-analytical errors as to was the blood drawn from the correct patient? Was there IV contamination? Those types of things. Was there a clot in the tube? So that when you see the word delta, it means let's check and see how this patient ran previously to make sure there's not a problem, a pre-analytical error that I'm not aware of. You also have your relative white blood count, which is the percentage of the particular cell counted for that 100 cells that is within the white blood cell differential. You also have an absolute white count, and that count is derived from the total white count multiplied by the percentage of that particular white cell. And you'll see both of those on the printout with the automation. So this kind of compares the relative versus the absolute white blood cell counts. For instance, if the white blood cell count is 5.0 multiplied by 10 to the 9th per liter, and you have a white blood cell differential of 40% segs, 3% bands, 55% lymphs, and 2% monos. So your lymphs are at 55%, but to determine the absolute value of the lymphs, the white blood cell count is multiplied by the relative percentage of the lymphs. So you have 5,000, which is the 5.0, multiplied by 0.55, which is converting the 55% to a decimal point, which gives you 2,750. And again, your automation is going to do this absolute count for you, but you just need to be aware what is the difference and how is this determined.